which is on endocrine disorders in pregnancy, which would be a webinar. And I'm happy to invite you all for this session, which would be interesting and I should say most wanted session as we end 2025. So without wasting much time, let us move on. And I would like to, Sahiti, you have shared the screen?
Ma'am, you can start
Wait,
sharing.
let me. Okay, fine. Okay. So I would like to invite our head of the department, Dr. Kundavi ma'am, to give her welcome address for our webinar.
Thank you, Dr. Geeta. On behalf of IRM and Madras Medical Mission, we welcome everyone for this webinar on endocrine disorders and pregnancy. And a special note for all the faculty, in spite of the busy schedule, they've joined us for this academic activity. And this is the last webinar for this year 2025. And I really thank all the faculties and the delegates who've joined us and supporting this academic activity. And I think Merry Christmas and Happy New Year to all the delegates and the faculty who are here. Over to you, Dr. Geeta.
Okay. So I would like to invite our first speaker for the session, Dr. Anjali Satya, with the topic of thyroid in pregnancy. And we do deal with thyroid right and left in our clinical practice. So happy to start this session. Ma'am is consultant endocrinologist from Vijaya Hospitals and Apollo Specialty Hospitals. Ma'am, over to you. You can start the session. You can share your slides, ma'am.
Thank you so much. Good afternoon, one and all. I wish to thank Dr. Kundavi and the Triple M team for this opportunity that's given to me. The topic assigned to me is on thyroid and pregnancy. So I'll just share my screen.
You can make it full screen, ma'am.
Yeah, I'm doing that. Yeah. So this is not a very unfamiliar topic to all of you, a very familiar topic because thyroid disorders are so common in our day-to-day clinical practice. So the agenda of my talk would be to discuss the salient features of thyroid, and probably I'll be discussing mainly on hypothyroidism in pregnancy, hyperthyroidism in pregnancy, and approach to thyroid nodules and cancer. So this is the depiction of the hypothalamo-pituitary axis. So we are talking about the mother here. So we know that the hypothalamus secretes the TRH, which acts on the pituitary thyrotropes that secretes the TSH. And the TSH works on the target organ thyroid gland to secrete the thyroid hormones, T4 and T3. And it's the T3, which is the biologically active form that acts on the tissue receptors to exert its action. Now, when we talk about the maternal-fetal barrier, here, placenta is a very active endocrine organ which acts as a select barrier, that it does not allow all the molecules to transport across the placenta to the fetus. So fetus is generally protected, or rather say being overwhelmed by wide fluctuations in maternal thyroid hormone levels. So TRH from the mother can cross the placenta. TSH, being a large molecule, cannot cross placenta. T3 and T4 can also cross placenta in smaller amount. And placenta has a very active deactivating enzyme called the deiodinase enzyme, which converts T4 to T3. And T3 is presented in small portions to the fetus. The T3 being the biologically active form protects the fetus because the fetal thyroid gland starts functioning only after about 15 weeks or so. So when we come to the physiological changes in pregnancy, now pregnancy is a estrogen-rich environment. So there is increase in all the globulins, including the thyroxine binding globulin that binds the thyroid protein. And that's why you see elevated total T4 levels when you check the thyroid levels in pregnant women. There is also a higher demand on the maternal thyroid gland because the mother has to supply thyroxine to the fetus because till 15 weeks the HPT axis in the fetus is not active. There is also higher iodine clearance in a pregnant mother. The beta HCG that goes up in the early weeks of pregnancy, it shares structural similarity with TSH. So the alpha subunit, both are glycoprotein hormones, and alpha subunit of beta HCG and thyroid TSH are same. They only differ in beta subunit. And because of beta HCG levels, there is TSH suppression in pregnancy, which I'll come to. Also, most of the autoimmune diseases, they start becoming milder because pregnancy is an immunosuppressed state. And that's why Graves' disease also starts improving in pregnancy. And many a time we are able to remove the patients of antithyroid drugs during pregnancy. Postpartum also we see changes. Graves' disease, there may be a relapse in Graves' disease. And also there is an entity called as postpartum thyroiditis, which I will explain to in the subsequent slides. So this is the commonest change that we see. The estrogen increase in TBG, it elevates the bound form of thyroid hormone. So when you check the total T4 in pregnant women, they may be elevated to almost like 1.5 times normal. Free T4 may be relatively spared of this change. And HCG, which peaks in the initial weeks, it increases by around week 10 and then it plateaus around week 16. And the high ECG, beta HCG, it stimulates the TSH receptor because it shares structural similarity. So instead of TSH, the beta HCG goes and binds the TSH receptor in the thyroid gland and stimulates it. And hence the TSH may be suppressed in the first trimester of pregnancy. And this is depicted in this diagram. But 10 weeks when the beta HCG peaks, the TSH becomes maximally suppressed. This suppression of TSH may be accentuated or augmented in multiple pregnancies. So in twin pregnancies, you may see this more often. And this subsides by usually 16 weeks and no treatment is required for this condition. Now, what about thyroid antibody? Do we need to test thyroid antibody routinely? The answer is no. The thyroid antibody, which is a marker of thyroid autoimmunity, if you look at the titers across the periods of gestation, the thyroid TPO antibody and even thyroglobulin antibody titers may come down as the pregnancy advances. Routine testing for thyroid antibody in women with euthyroid state is not recommended. And levothyroxine treatment is also not recommended for those women who are already thyroid antibody positive, but are actually euthyroid. If their thyroid functions are normal in pregnancy, even if they have thyroid antibodies, there is no indication to treat, but they need to be followed up during pregnancy. So coming to the embryogenesis in the fetus, as I mentioned earlier, structurally, the thyroid gland is visible by around 10 weeks in a fetus, but functional development, you see it complete only by around 20 weeks. The hypothalamo-pituitary thyroid axis is fully established only by around 20 weeks. That's about 5 months of pregnancy. So the initial 5 months is the maternal thyroid hormone, which crosses the placenta and supplies the thyroxine for the fetus. And it's extremely important for the neuronal migration and neuropsychological development of the fetal brain. Defining hypothyroidism, these are the terms that we normally use. Of overt hypothyroidism, where the T4 levels are low and TSH is beyond the trimester-specific range more than 10. Subclinical hypothyroid would be a state where TSH is between 4 to 10, but free T4 and free T3 levels are normal. Isolated hypothyroxanemia is a condition where the TSH is normal, but the free T4 would be between 2.5 to 5th centile of normal. This entity, whether we need to treat or not, is a question. So we'll be coming to that. So why do we treat hypothyroidism? Now, both overt and subclinical hypothyroidism are important to treat in pregnancy because untreated hypothyroidism leads to adverse outcomes in both mother and the fetus. In the mother, it increases the risk for preeclampsia, gestational hypertension, placental abruption, preterm delivery, increased rate of C-sections. In the fetus, again, it's associated with preterm birth, perinatal morbidity, mortality, increased NICU admissions, neuropsychological and cognitive delay, and congenital cretinism, which is no longer seen after the iodization program in India, is again a very bad disease to have and should be prevented at all costs. The risk compared to overt hypothyroidism, the risk in subclinical hypothyroidism is much lesser, but it is there. And thus, we need to treat both subclinical and overt hypothyroidism in pregnant women. So let's go to the case 1, where a young lady comes for her first antenatal visit. Her cycles were regular prior to conception, and as part of her first antenatal checkup, her obstetrician offers her these tests, and her TSH was found to be 5.2. T4 was 11.2, higher limit of normal, which I mentioned in the earlier, the total T4 will be elevated to almost like 1.5 times the upper limit of non-pregnant range. The TFT done 1 year ago for this woman was normal. She had done it as part of a general checkup. Family history, a mother and grandmother, they are on thyroxine for hypothyroidism. And her obstetrician asked for a thyroid antibodies as because she found the TSH to be borderline, and that was found to be more than 1,000. So this is a clear-cut case of a subclinical hypothyroidism. The question arises, should we screen all antenatal mothers for thyroid dysfunction? Should we treat this condition irrespective of the thyroid antibody status? What should be the TSH cutoffs that we need to adopt? Do we need to adopt trimester-specific ranges for pregnancy? What should be the recommended iodine intake for such an individual? And if she is already on thyroxine, how much dose increment is required? So this is a woman who was first found to have hypothyroidism in pregnancy. Now, targeted screening versus universal screening, as you all know that the disease prevalence in Indian population is quite high. And this was quite evident in these studies, which looked at prevalence of thyroid dysfunction among young women in South Indian population, where overt hypothyroidism was seen in 1.3%, and subclinical was seen in almost like close to 10% of pregnant women. This was a study which was conducted across 9 states in India. And there also the prevalences were quite high in various states, as is seen. Almost 13% of pregnant women had hypo, and using a cutoff of 4.5. And antibodies were seen in almost 20% of pregnant women. So there have been several studies from India, but they have all used different cutoffs. The ATA guidelines were using the American cutoffs, but now we have data from our own country. And in countries where there is no data, generally for Southeast Asians, higher TSH cutoffs are accepted. So targeted screening is recommended in the Western nations where the prevalence is lower, where they offer thyroid test only to women who have thyroid antibody positivity, strong family history. They have history of type 1 diabetes or other autoimmune conditions, history of head and neck radiation, history of bad obstetric history in the past, multiple prior pregnancies, morbid obesity, use of drugs which can affect thyroid function, and residing in an area which is associated with thyroid deficiency. But we in India, we follow universal screening. So universal screening is recommended for all pregnant women in the first trimester. And if, what they have found is when you compare targeted screening versus universal, we may miss up to almost 49% of pregnant women with subclinical thyroid dysfunction. And that's why we need to target these all pregnant women and treat them accordingly. What should be the normal reference range for serum TSH? Now, because of the effect of beta HCG, the non-pregnant cutoffs for TSH is 0.3 to 4.2 in most laboratories. This may fall down by 0.1 to 0.2. The lower range and the upper limit may again fall by around 0.5 to 1 in pregnancy because of the effect of beta HCG. So we need to have population-specific and even trimester-specific cutoffs for TSH. And if data is not available in Southeast Asians, we accept a cutoff of 4. Now, in India, Rajput R. et al. From Haryana, he had actually presented a paper on trimester-specific cutoffs. And it was found that with progression of pregnancy, the mean TSH actually increased and the T3 level decreased. The free T4 level also, if you monitor across trimester, the first trimester, and then you watch the FT4 to the third trimester, you see a fall. But the difference is not very significant. So when he calculated, he looked at the 2.5 to 97.5 centile of FT3, FT4, TSH. And these cutoffs are obtained from normal women who do not have thyroid disease and who are thyroid antibody negative and who are from iodine replete area. So that is a background population that is chosen for deciding the TSH cutoffs. And this was what he found, that in first trimester, the TSH was between 0.37 to 3.69, and second trimester 0.5 to 4.47, and third 0.7 to 4.6. So taking a cutoff of 4 is probably quite well acceptable in our population to start treating. So do we do free T4 or total T4? Again, it all depends on the assays available. The most accurate test for FT4 or free T4 would be equilibrium dialysis or ultrafiltration, which is very cumbersome and costly, not available. What we normally use is immunoassays, which are automated. And that can be complicated by levels of thyroxine binding globulin in the plasma, albumin level, non-esterified fatty acids. So all this can alter the free T4 level. So now the general consensus is you can actually look at total T4, which is more preferable, which are not sort of affected by the concentrations of TBG, NEFA, or albumin levels. So total T4 may be definitely superior. Only thing you have to remember is total T4 is it's elevated normally up to almost 1.5 times normal. So coming to iodine nutrition of a pregnant mother, never restrict iodine. It's a very important micronutrient. And if there is iodine deficiency, it can affect the mother, the fetus, and the child. So reduced thyroid hormone production and goiter in mother and child results from iodine deficiency. And mothers with severe iodine deficiency, it is the maternal pregnancy outcome itself is affected because of higher rates of pregnancy loss, stillbirth, and increased infant and child mortality. The baby also gets affected, and the adverse effects are seen on the cognitive function in the offspring. The children may exhibit cretinism because of maternal iodine deficiency, characterized with profound intellectual impairment, deaf mutism. And these are no longer seen because ever since the iodization program came into India, we do not see cretins anymore. And so iodine replacement is extremely important. So the iodine supplementation, it's ideal that pre-pregnancy women get at least 150 microgram of iodine. We have it in our salts. In fact, our salts are iodized to a much larger concentration than the recommended amount. And during pregnancy, pregnant women should ingest 250 microgram of iodine. So those who are on regular thyroxine supplement need not have a supplemental iodine according to diet because the thyroid gland is non-functional in them. Now, do we treat isolated hypothyroxemia? This is a condition, as I said, where the TSH is normal, but the FT4 is less than the 2.5 percentile of normal range. So FT4 is low, but TSH is normal. Now, this condition has been found to be associated with various adverse outcomes in pregnancy, even in the fetus. It leads to lower IQ, language delay, worsened motor function, smaller head circumference, and increased risk of autism in children. An association with higher risk for premature delivery has also been seen. But we don't have enough evidence to support thyroxine administration in these group of women who have normal TSH but low T4. So at this time, because we don't have strong evidence, it cannot be recommended that these group of women should be treated with thyroxine. Now, this was the paper in New England Journal of Medicine, which looked at the effect of hypothyroidism on the IQ scales in the babies. And children of untreated women with hypothyroidism did show a significant reduction in IQ score to a tune of 10 points. Which might be, significant. And so treating hypothyroidism to whatever degree is extremely important. We need to identify subclinical hypo and overt hypo in pregnant women. The recent guidelines from RCOG, which was published in BMJ, also sort of affirms, it agrees with whatever Endocrine Society also says, is that women should be counseled to self-initiate an empirical dose. Like a woman who is already on thyroxine for hypothyroidism can be told to take 2 extra tablets per week before she makes her first antinatal visit to the to the obstetrician or to sees her endocrinologist. So somebody who is already on replacement would require an extra dose once she gets pregnant. So 2 extra tablets per week is recommended. And initial weeks of pregnancy, we monitor thyroid every 4 to 6 weeks until 20 weeks, and thereafter requirement is seen. Aim is to keep the TSH less than 2.5 in the first trimester and less than 3 second and third trimester. Now, role of thyroid autoimmunity and pregnancy complications. Autoimmune thyroid disease is the most common cause for hypothyroidism, and TPO antibodies is what is usually studied in most of the studies. And what they have said is someone who already has, like this woman had high thyroid antibodies, and if she is supposed found to have a normal TSH prior to pregnancy, and she has a high thyroid antibody, her risk for developing hypothyroidism during pregnancy is very high. So once she confirms her pregnancy, she should monitor her thyroid in the initial till about 20th week. She should monitor it closely, and if there is a hypothyroidism that develops during pregnancy, it should be treated. But someone who is antibody positive but has normal thyroid function in pregnancy need not be treated. Selenium supplementation has a role in thyroid eye disease, but no role in hypothyroidism. So thyroid autoimmunity, generally it reflects a generalized activation of the immune system. So it has been found to be associated with higher miscarriage rates and high rates of preterm delivery. This has been substantiated in many cohort studies, and it has been very strongly seen that there is a high correlation between high thyroid antibodies and recurrent miscarriages. And so a woman who has autoimmune thyroid disease, even with subclinical, it is strongly recommended to treat them. There's no role for IV immunoglobulin as an immunosuppressive agent. Now, do we need to treat women with TSH between 2.5 to 4? Because that's the cutoff which we recommend for pregnancy. So they have said we have to probably see on a case-to-case basis. A woman who is older woman who is going for assisted conception, a woman with recurrent miscarriages, probably we have a case for treating those women who have TSH between 2.5 to 4, but thyroid antibody positive, to treat them in small dose of thyroxine. So somebody who is planning pregnancy, it is very, very important to counsel them pre-conceptually that they should check their thyroid levels, someone who is on thyroxine, to check their thyroid levels before planning pregnancy. And the pre-conception TSH should be kept less than 2.5. And we should also tell them that the dose has to be increased during pregnancy. So they should come as soon as they test positive. The dose may have to be increased by almost 2.5, 25 to 30%. Or as I mentioned earlier, we can instruct them that once they conceive, they can take 2 extra tablets per week. So we should always use levothyroxine for treatment. Now you would have heard of combination therapies available, where some women do use T3 and T4 combination prior to pregnancy. Now in pregnancy, we do not recommend usage of T3. So they should switch over. If they are on a combo regimen, they should switch over to levothyroxine therapy. So thyroid antibody positive women with TSH greater than 4 definitely should be treated. Even any woman who has TSH above 4, irrespective of the thyroid antibody, whether positive or negative, we would treat in our scenario. So this is what I think, this is a repeat of what I mentioned. So we should treat all women who have TSH above 4 during pregnancy. And the dosage for subclinical hypo, as in this woman, we would use a dosage of 1.2 microgram per kilogram body weight. And for overt hypothyroidism, we generally use a cutoff of 1.6 microgram per kg body weight. The target goal would be keeping the maternal TSH less than 2.5 in first trimester and less than 3 in second and third. Now, what if this particular patient whom I had mentioned earlier comes with a TSH of say 140 in pregnancy, overt full-blown hypothyroidism diagnosed for the first time? There also we should not panic. Definitely termination of pregnancy is not advisable, though there is always a concern that the fetus is exposed to a period of severe hypothyroidism. Here we try to use a little higher dose of replacement initially. So instead of 1.6 microgram per kg body weight, we can use up to 2 to 2.5 microgram kg body weight and rapidly normalize the thyroxine, and thereafter we can do a weight-based calculation. So generally, severe hypothyroidism also we treat them with higher dose of thyroxine initially to normalize and then maintain. Postpartum period, we go back to the pre-pregnancy level. Somebody who had subclinical hypo, we may actually even decide to stop and reassess them 6 weeks postpartum. And those who are women who are antibody positive, there is a high risk for them to develop what is known as postpartum thyroiditis, which can happen, manifest immediately after delivery. It has 3 phases, a thyrotoxic phase, and they may develop hypothyroidism at 6 months postpartum. So antibody positive mothers, if we decide to stop their thyroxine, they should be kept under close watch to watch for postpartum thyroiditis. And these women are also at higher risk for postpartum depression. So the second case that I'm presenting is a 28-year-old young lady who conceived with ovulation induction with clomiphene, and she has a twin pregnancy. She was admitted twice with hyperemesis gravidarum, has lost 4 kilos. She has she didn't have overt palpitation, no other symptoms suggestive of thyrotoxicosis. There's no family history of autoimmune thyroid disease. On examination, she was pale. There was no palpable thyroid gland. No other signs suggestive of Graves' disease. Heart rate was on the higher side, 100 per minute, and cardiovascular system was normal. So this is again a very common presentation you may come across in your clinical practice, especially seen with multiple pregnancies. Here again, the beta HCG titers are extremely high in twin pregnancies, and that can stimulate the TSH receptor, causing what is known as gestational thyrotoxicosis. Now, it's very important to, when a woman comes with this condition, whether this is an underlying Graves' disease or is it a gestational thyrotoxicosis, because treatment is very important in Graves' disease, whereas in gestational thyrotoxicosis, which is self-limiting, we normally do not intervene. So the point of differentiation would be presence of symptoms prior to pregnancy. So if a woman has a visible goiter and she had symptoms antedating pregnancy, and she has low TSH, grossly elevated T4, they may even have a higher T3 than T4, that would be more in favor of Graves' disease. The other test that we do is to check for TSH receptor antibody. Now that is positive in women with Graves' disease, whereas it would be negative in women with gestational thyrotoxicosis. Women with gestational thyrotoxicosis are symptomatic only after conception. They don't have goiter, TRAB negative, and the T3 levels or T3, T4 ratios will be less than 20. So these are differentiating features, very important to differentiate between gestational thyrotoxicosis versus underlying Graves' disease. Let's look at the next patient, who is again a young woman who is known to have Graves' disease, has been on antithyroid drugs for almost 2 years. She's currently on 5 milligram of methimazole. Her TSH receptor antibody titers are 1.8, which is almost normal. She's euthyroid on this dose, which is considered a very small dose of antithyroid drug. Now, if she conceives, what is the best advice that can be offered? Should we change to PTU till 16 weeks or stop antithyroid drugs altogether? How frequently we should monitor in pregnancy, and how to do fetal surveillance in these cases? So women who are clinically euthyroid on minimal dose of antithyroid drugs, even prior to pregnancy, we can actually stop their antithyroid drugs. Because theoretically, both the antithyroid drugs, that is carbimazole and propylthiouracil, can cross the placenta. Only 2 to 3% of fetuses may show teratogenic effects, but even that is significant. So it is given a choice, we should try not to use antithyroid drugs in the first trimester. But if a woman is grossly hyperthyroid, then of course the medication of choice would be propylthiouracil, which is more protein bound, and the transplacental transfer to the fetus is less compared to carbimazole. So PTU is offered in severe thyrotoxicosis, or a woman who requires high dose of antithyroid drugs prior to pregnancy. So PTU, this is the only scenario where we use propylthiouracil the first trimester of pregnancy, and it is continued till about 16 weeks. As I mentioned earlier, the Graves' disease actually improves as the period of gestation advances. And many a time by second trimester itself, we are able to withdraw the patients of antithyroid drugs. So we monitor their thyroid function. And also we look at the TRAB titer. Somebody who is on antithyroid drug, we would check her TRAB titer in the first trimester. If it is high, then we have to monitor. We have to follow it up even in third trimester, because if there is a jump in TSH receptor antibody, say more than 3 times normal, the risk for the fetal thyrotoxicosis is very high. And so strong fetal surveillance is advised in those patients who have high TRAB titers. So in ultrasound, fetal tachycardia is looked for, or presence of fetal goiters are looked for. And in certain scenarios, we may have to treat the mother with antithyroid drug. And this is what is depicted in the next patient. Patient who had undergone total thyroidectomy for Graves' disease. Now, TSH receptor antibody crosses the placenta and can go affect the fetus. Now, even if the woman undergoes radioactive iodine therapy for Graves' disease or thyroidectomy, the TRAb titers may remain positive in her, and it has relevance in pregnancy. So this woman had undergone surgery. She gets pregnant 1 year later. Fetal tachycardia was noted during the 3rd trimester, and ultrasound reveals a large fetal goiter. The TRAb titers for the mother were elevated. The mother is currently on 125 microgram of thyroxine because she had surgery. She is euthyroid, but her TRAb titers are positive, and that is causing the fetal thyrotoxicosis. In this case, we would monitor the fetal heart rate, the goiter size, amniotic fluid volume, and also intrauterine growth. And here we treat the mother with antithyroid drug, that is methimazole, to control the fetal tachycardia. My presentation would be incomplete in hypothyroidism if I don't mention that all newborn babies must be screened for neonatal hypothyroidism. The last case that I'm going to present is a young woman who was found to have a 1 centimeter nodule in the right thyroid lobe during the 9th week of pregnancy. She felt it when she was feeling her neck, and she felt there was something nodular there, and she had an ultrasound done. The family history, there's negative for thyroid cancer and goiters. Ultrasound showed a thyroid 3 nodule with no suspicious features. And so the FNAC was deferred initially and by the endocrinologist that she had seen. At 18 weeks, the nodule had doubled in size. She felt the nodule is increasing in size. And again, a repeat ultrasound was done, which showed a 2 centimeter ipsilateral cervical lymph node. The FNA revealed a papillary CA thyroid with lymph node mets. The TSH remained normal. So here is a thyroid nodule. Normally, thyroid nodules, whether benign or, if they have benign features, in fact, the FNA can be postponed even post-delivery. There's no rush to do an FNAC during pregnancy. But if there are some sinister features, like taller than wider nodule or presence of microcalcification, where you feel there is a suspicion of malignancy, thyroids 4 and above, we do the FNAC even during pregnancy. Now, if it's a nodule which is stable during pregnancy, we do not need to operate. Again, surgery can be postponed. But here is a nodule which has almost doubled in size. And again, a lymph node has appeared in the neck, which is showing metastasis. So here, the best thing to do would be to offer her total thyroidectomy, and that should be offered in the 2nd trimester of pregnancy. So thyroid nodules in pregnancy, the approach would be very much similar to a woman who is not pregnant. So detailed history should be taken. Physical examination should be looked. We should look for neck lymph nodes or size of the nodule if there are any signs of compression. Ultrasound thyroid, the nodules are graded, and we call it as a thyroid's grading. Any thyroids 3 should be definitely observed. 4 and above are definitely suspicious. And based on the size, they are offered a fine needle aspiration cytology. And TSH should be tested for all these women. A woman who comes with a nodule and you find the first test that we normally do in these women, even before ultrasound, is a TSH. If you find that TSH is suppressed and the woman has a nodule, it could be a toxic nodule. And we can always evaluate them later if there are no gross symptoms. We do not offer any nuclear scans to pregnant women or potentially pregnant women or those women who are lactating. So nuclear studies are definitely not offered, and we do only ultrasounds. So newly diagnosed thyroid carcinoma in any pregnant woman, we can consider surgery during the 2nd trimester if there is growth in those nodules by 24 weeks. Stable nodules, even though they may be cancerous, we can offer surgery after delivery. So that will not change the prognosis of the nodule, because thyroid nodules are extremely slow growing. If you see a rapid growth during pregnancy, it could be an aggressive cancer. So in that case, surgery should be offered before 22 weeks. And if we decide to follow up a thyroid nodule, which is found to be thyroid malignant, differentiated CA thyroid, then we can actually start them on small dose of thyroxine to keep the TSH in the lower limit of normal, because that prevents the growth of the nodule during pregnancy. So when the decision is taken to postpone surgery after delivery, we start them on small suppressive dose of thyroxine to keep the TSH on the lower limit of normal. So the carry home message from these slides are that thyroid disorders are extremely common in pregnant women. In our population, the prevalence is very high. So screen all pregnant women for thyroid dysfunction. Treat both overt and subclinical hypothyroidism. The cutoffs that we use is values above 4. In certain scenarios, we may choose to treat even those women who are having TSH above 2.5 on a case-to-case basis with bad obstetric outcome, recurrent miscarriages. A woman who is going for assisted conception, we would definitely like her TSH to remain less than 3 prior to conception. In early pregnancy, the thyroid testing should be done more often, 4 to 6 weeks. And after third trimester, we check once at 28 weeks. Whenever we give thyroxine to a pregnant woman, remember, iron and thyroxine should be spaced by 4 hours. And we should also look for other autoimmune conditions in pregnancy, like vitamin B12 deficiency. They may have other autoimmune conditions as well. And all newborns should be offered thyroid testing. Pre-pregnancy counseling, extremely important. A woman who is already hypothyroid on medication, we should tell them that a higher dose is required. Somebody who has been ablated with radioactive iodine for Graves' disease, pregnancy should be postponed by 6 months. Definitely, if she conceives within 6 months, the newborn may have congenital hypothyroidism. We would, for safer side, we tell them to conceive after 1 year. So avoid conception for 6 months after radioactive iodine. First trimester of pregnancy, hyperthyroidism, we use PTU as a preferred drug of choice given till 16 weeks of pregnancy. And subsequently, we change over to methimazole. And thyroid function should be closely followed up. And women who are thyrotoxic, TSH receptor antibodies are followed up both in first trimester and third trimester. If there is increase in titer of TSH receptor antibody, there is a higher risk for fetal thyrotoxicosis, and fetal surveillance is very important. A woman who gives previous history of thyroid cancer, we definitely wait for 1 year after ablation. Sometimes they may have metastatic disease, but then if they are young and they want to plan pregnancy, if their thyroglobulins are well suppressed, we do allow them to get pregnant, and follow-up can be done later. So with that, I conclude my talk. And if there are any questions, I'll be happy to. Thank you.
Thank you, ma'am. Thank you so much for highlighting points on thyroid and pregnancy. And the way you led the session with case-based discussion was quite interesting. And with very crisp take-home messages you have given this session. Thank you so much. And we don't have any doubts as of now. Maybe we can take up the questions prior panel discussion. So we can move on to the next session. Ma'am, you can stop sharing your slides. I would like to invite our next speaker, Dr. Jayashree Gopal ma'am, for her next talk, which would be on hyperprolactinemia and pregnancy. Ma'am is a director of Diab Endo India in Chennai, and she's consultant from Kaveri Hospital. Over to you, ma'am. You can start with the hyperprolactinemia. Yes, ma'am. You can start sharing your slides.
Yeah. Let me just, is it full screen?
Yes, ma'am. Yeah.
Okay, thank you. Thank you, Dr. Geeta, Dr. Kundavai, for inviting me. And I think Anjali had a very comprehensive talk on thyroid and pregnancy. Mine is not going to be that long. But just very 4 simple cases I'll be talking about. Just 1 minute, yeah. So I think we all understand it's I think the management of prolactin disorders and pregnancy is not that complicated. So the only issue is when do we treat, when do we stop, when do we continue, say, cabergoline in pregnancy. So it's not very many decisions with interpretation, etc., like in the thyroid. We understand that prolactin is necessary for normal ovulation and fertility. And in this somewhat busy slide, but I think it's a very good slide. It just sort of gives you in one part all of the actions of prolactin. We understand its action on the HPG axis. It inhibits the GnRH pulses So prolactin levels, if they're not in order, the GnRH pulses get affected, and then you'll end up with anovulation. But it's also necessary for formation of the corpus luteum and the progesterone secretion. In fact, now it has been found that there is local prolactin production in the ovary. So the pituitary is not the only source of the prolactin production. The local production of prolactin is necessary for this proper formation of the corpus luteum and the progesterone secretion. And of course, we understand its main action, which is the action on the mammary gland, which is the adaptation to the breastfeeding, the ductal gland development and secretion of milk. Prolactin is also involved, like the growth hormone, in growth and development. It also has a role to play in the beta cell proliferation and improving the insulin secretion. It also has another very important role to play in regulating sodium water transport across the plasma membranes. In fact, clinically, one of the correlates with this is quite often when women present to us with a slightly high prolactin, they tend to have a little bit of water retention. And once you put them on a prolactin lowering agent, that water retention gets better. So these are all the physiological actions of prolactin, as it were. And when the prolactin levels increase, we understand all the pathological correlates, particularly related to delayed puberty in younger ages, but more important, ovarian dysfunction and anovulation. This was a nice paper published. This was in 2018, sorry, it was 1998. One of the earliest studies which showed, this was a rat study, and I just like this because it shows how closely the prolactin surges are related to the LH surges. So this is in suckling suckling rhesus monkeys, and this open bar here just shows the period of suckling. So you can see that as soon as they start suckling, the prolactin starts going up, the LH and the estradiol levels and the progesterone, everything suppresses. And as long as they are suckling constantly all through the day, the prolactin levels remain high and there is no LH surge. So you can see clearly how much it inhibits ovulation. Then in this trial, what they did was in the period of suckling, they also gave bromocriptine. And you can see that as soon as they give bromocriptine, which is this black bars here, as soon as they give bromocriptine, prolactin comes down, the LH surge occurs, the estrogen surge occurs, progesterone surge occurs. So you can see how closely it is correlated. The prolactin and the LH surges, and thereby the ovulation, and not only the ovulation, but also formation of the corpus luteum. And the time-bound event, that it is an immediate action. As soon as you give the bromocriptine, the prolactin comes down and these LS again surges up. Yeah. This was a nice statement, and I think it's important to keep it in mind. The statement says a certain level of prolactin circulating in the blood, as well as what is produced locally in reproductive tissues, may be necessary for optimal oocyte development, formation and maintenance of the corpus luteum, as well as blastocyst implantation, steroidogenesis in early pregnancy, and modulation of the immune system. So this, I just put it in to, I think, reiterate or drive home the point about how important maintaining normal prolactin levels are in women who are trying to conceive. So moving on to the first case, I think this is one of the commonest scenarios, a mild hyperprolactinemia in the context of PCOS. So let's say we have a 32-year-old lady with PCOS, the prolactin level varying between 35 to 40. And this is very, very common. And it is confirmed on repeated tests. We do it in a fasting state. She does have regular cycles. She is ovulatory, but she's trying to conceive and it is not happening. So do we treat it? Of course, we are taught that you don't need to measure a prolactin in a situation like this, where the periods are regular. But of course, because she's approached you for trying to conceive and that is getting delayed, I think it is reasonable to check a prolactin. And if it is elevated, to go ahead and treat. And I'll share the data regarding that. Mild prolactin elevation is common in PCOS, and we all know this is the chicken and egg. Is it the PCOS causing a slightly high prolactin, or is it the borderline high prolactin causing an increase in the PCOS? Interestingly, our Endocrine Society guidelines say that the initial determination of serum prolactin should avoid excessive venipuncture stress, but that it can be drawn at any time of the day. I think for practical purposes, most of us advise that it be done on an empty stomach between to the 2nd to the 5th day of the menstrual cycle, just to make sure that you don't have any other. At the time of the LH surge, you might have a change in the prolactin level. Just before the LH surge, you'll sometimes see a very high prolactin level. So I think it makes sense to do it between the 2nd to the 5th day of the cycle. and to do it on an empty stomach so that you're taking away all of the other confounders around measuring the prolactin hormone. A single determination is usually sufficient to establish the diagnosis of hyperprolactinemia, but some centers actually do sampling. They take 3 samples at 15 to 20 minute intervals. So they put in a catheter in place and they check the prolactin 3 times or 4 times, and they take an average of the prolactin levels. I've seen some centers in India also doing this. In general, I think most of us just do a fasting prolactin, repeated 2 or 3 times. And remember to always recheck and fasting and measure it along with the macroprolactin. Macroprolactin, again, what I find is the levels vary. Macroprolactin is positive once, very rarely positive. I would say 90% of the time, I find that it's negative. Some people, it does come back as saying, they'll give a report saying macroprolactin is present to a certain degree. But these people, if you repeat the test 2 or 3 times, that measurement of the macroprolactin also keeps varying from time to time. So I'm not quite sure how useful it is, but this is the recommendation that we do it, repeat it, ideally do it on a fasting sample for confirmation, and measure it with a macroprolactin to rule out macroprolactinemia. We understand all of the reasons why prolactin levels go up. It can happen either because dopamine is shut off, particularly with neuroleptic psychotropic agents and particularly with proton pump inhibitors. When you take away the negative feedback of dopamine, prolactin levels will go up. The positive influence of estrogen is particularly seen in pregnancy. And of course, another very important thing to keep in mind is obviously primary hypothyroidism and adrenal insufficiency. And both of this, because of increased TRH production, prolactin levels can go up. So I think we're all familiar with this. Other, of course, pituitary adenomas, stalk interruption, say post-traumatic injury, many reasons why prolactin levels can go up, but the 2 most important being hypothyroidism and medications. These are the 2 things that we need to keep in mind. Coming back to prolactin and PCOS, this was a study which was published where they took women diagnosed with PCOS and they measured their prolactin levels. And what they found was that 2/3 of the women had a normal prolactin. In 21%, the slightly elevated prolactin could be accounted for by a macroprolactin. In about 10% of women, they had a pituitary adenoma, and the remaining 5%, they classified it as idiopathic, meaning they couldn't find a cause and presumed that it was because of the PCOS itself. And this is interesting to compare the prolactin levels, because this is where I think we always get a doubt. How high should the prolactin be? And you can see that in normal women, prolactin is around 16. In the macroprolactin group, prolactin comes back as 41. In the group that was subsequently diagnosed as pituitary adenoma, the prolactin level is around 60. In the group that is classified as idiopathic, it's around 44. So I would say there isn't much difference really, around 45, but certainly I think above 50, we have to start thinking about pituitary microadenomas. But this was the prolactin levels in this particular study. Many studies have shown that treatment of women with PCOS and infertility with a slightly elevated prolactin level with bromocriptine or with crebagoline helps to improve ovulation rates. So they'll consistently find that the ovulation rate is at least about 1.5 to 2 times better when it is treated either with bromocriptine or with crebagoline as compared to a group that is not treated with such. And that the pregnancy rates are also better. For example, in this particular study, pregnancy rate was about 28 to 30% versus 12 to 15% in the group that was not treated with bromocriptine. So what I pulled up in this were studies where women had PCOS, mild elevations in prolactin, and difficulty in getting pregnant. In all of these situations, I think it makes sense to put women on crebagoline and keep them on a minimal dose of crebagoline. Levels come down, you stop the crebagoline, again the prolactin will shoot back up. So what I've taken to doing is just tapering it. So if they're on a weekly once and your prolactin levels are around 10 or 12, leave them on it. If it's going very low, dropping to below 2 and they've still not conceived, go to once in 10 days or once in 2 weeks. Some minimal dose can be continued. Try to keep the prolactin levels in some normal range till they conceive. Once pregnancy is confirmed, then the crebagoline can be stopped. So borderline elevations of prolactin in PCOS, if it's usually
Excuse me, ma'am, we can't hear you. Sahiti?
Geeta, what's happening?
I think there was some problem with Dr. Jayashree, ma'am. Let me just find out, ma'am. Just give me a minute. Some signal problem with her talk, I think. Ma'am, can you hear us? Jayashree, ma'am? Ma'am?
1 second.
Now we can hear you.
Yeah. Sorry.
Okay, ma'am.
Sorry, I got connected. I don't know till what you heard.
You can go ahead, ma'am. You can go ahead.
Hello?
Yes, ma'am. You can go ahead now.
Okay. So let's say we have another case, a 29-year-old woman who is planning for a pregnancy, and she's been diagnosed with a 6 mm pituitary microadenoma. Microadenomas have very low pregnancy growth risk. So after she conceives, you can just stop the cabergoline, and there is no need to routinely monitor prolactin in pregnancy. You can just monitor them for headaches and visual symptoms. So that is more important in a macroprolactinoma. And in a microprolactinoma, you stop the dopamine agonist, whether they've been on bromocriptine or cabergoline, once pregnancy is confirmed. But let's say you have a lady with a macroprolactinoma. So I've just put up a case of a 35-year-old lady who presented with the classical features of a high prolactin, amenorrhea, galactorrhea, infertility, prolactin very high. MRI shows an 80 mm macroprolactinoma with no optic chiasm compression. In this, we have to be a little bit more careful because macroprolactinomas, in general, it is estimated they carry about a 20% risk of significant enlargement during pregnancy. The risk is much higher, particularly the larger the size, with suprasellar extension, and if there has been no prior tumor debulking done with surgery. Whether or not to continue cabergoline in pregnancy will depend on whether there are high-risk features. But one thing is there's no point in measuring serum prolactin in pregnancy because you will have the physiological rise in pregnancy and it correlates very poorly with growth of the adenoma in pregnancy. What we do need to do is to clinically review these women for symptoms. Is there any new or worsening headache? Is there any visual disturbance? If they've had a visual field checkup done earlier, we can consider doing a formal visual field testing every 3 months. And an MRI without contrast would be suggested only if the symptoms suggest tumor growth, an onset of headache or visual complaints, severe headache, visual complaints, you can get them to an MRI. There are some predictors of more aggressive growth with macroprolactinomas. One is the MRI itself showing, if it is showing a cavernous or a suprasellar invasion. If the macroadenomas responded well to the dopamine agonist, to cabergoline, and that prolactin dropped rapidly, and you did an MRI within 6 months and it showed a good shrinkage, chances of it increasing in pregnancy are very low. However, if you have had her on cabergoline and there has been only poor or partial response, then this is the type of adenoma that you would consider more chances of increasing size and pregnancy, and you might consider doing a surgical debulking before planning surgery. If the symptoms again are stable or improving versus progressive, if for some reason, if you've done a transperineal resection and you have a pathological tissue, you can do something called a Ki67 marker, which is a marker of proliferation. If the Ki67 marker is very low, the chances of growth and pregnancy are very low. If it is high, that means there's a high chance that this adenoma is going to increase in size in pregnancy. Adenomas on MRI, there is something called the NOSP grading. NOSP grading just tells you how close is it to the how much will it how much is it pressing on the internal carotid artery and the cavernous sinus, and the higher the grading of the knobs, so that is, it is encasing the carotid artery or it is going out. These are the types of tumors which will tend to increase in size more during pregnancy. So this is something that we can look at on the pre-pregnancy MRI and determine. If you start off like this, but after treatment she shrunk to something like this, then during pregnancy, there is still a chance that it will grow, but you can keep a careful eye on her. But this is somebody there where you might consider continuing the cabergoline in pregnancy. So dopamine agonists are usually stopped in macroprolactinomas at pregnancy confirmation. Exception are very large invasive macroprolactinomas where you're worried about constant growth. Dopamine agonists may be continued. And if in pregnancy symptomatic growth occurs, you've stopped it, but during pregnancy she develops a headache, you do an MRI, it is increased, you can restart the dopamine agonist. Bromocriptine is preferred in pregnancy because there is just more data using bromocriptine in pregnancy. Though cabergoline can be used, and there are plenty of case reports showing the safety of cabergoline when used in pregnancy. Surgery is necessary if the tumor enlarges despite dopamine agonist, and like Anjali said, always surgery is recommended in the second trimester or an early delivery if the gestational age allows. And finally, one case, a 34-year-old lady with schizophrenia on risperidone with a prolactin of 110. She is amenorrheic and she desires a pregnancy. To confirm that this is a antipsychotic medication-induced hyperprolactinemia, it's always better to check an MRI to exclude a macroadenoma. Once you know that the MRI is normal, then you can switch them over to a prolactin-sparing antipsychotic, something like aripiprazole. Though the aripiprazole may also cause elevations of prolactin, it may not be to the extent with certain other antipsychotic agents. We have to be careful about introducing dopamine agonists in people on antipsychotic agents because there have been some case reports where introduction of cabergoline has worsened psychosis. In this situation, the first line approach is to switch the prolactin-sparing antipsychotic, repeat a prolactin, see whether it comes down, see whether she's able to conceive on her own. And once she's very stable and she doesn't have any psychotic episode for some time, and the psychiatrist is also, in the discussion loop that they are not at chances of having psychosis worsening, at that point in time, you can have. So to summarize, prolactin, both systemic and local, is needed for ovulation and fertility. Borderline elevations of prolactin is common in PCOS. We do not need to treat if they are asymptomatic. But addition of cabergoline, particularly in mild, marginally elevated prolactin levels in PCOS, has been shown to improve ovulation rates. If it's a microprolactinoma diagnosis prior to pregnancy, dopamine agonist can be stopped after pregnancy is diagnosed. If it's a macroprolactinoma with high-risk features, it is extending a lot, it hasn't responded well to medications, they're very symptomatic, they will need to continue dopamine agonist in pregnancy. And finally, remember, prolactin elevations are very common. Always confirm elevated levels with repeated testing, ideally in the fasting state and between the 2nd to the 5th day of the cycle. I'll stop here and happy to answer any questions if there are.
Thank you, ma'am. Thank you so much for taking us through prolactin problems in pregnancy. We do have some 2 questions, but I think it's not related to prolactin, but I mean, I would be happy if you help us, Dr. Anjali is not here. Ma'am, the question is, should we take drugs for thyroid profile only in fasting state?
So TSH, it is said that it doesn't matter because TSH doesn't vary too much based on fasting or not eating. So the Endocrine Society says you can do it at any time. However, TSH levels, there is a little bit of a surge between 4 to 5 p.m. in the evening, or 4 to 6 p.m. There is a little bit of a surge. So when you're trying to decide whether you want to treat borderline elevations or not, it's always better to check a TSH on an empty stomach. And if they're on thyroid tablets, before they take thyroid tablets, so that you get a more consistent measurement.
Okay.
And free T4 definitely varies with food intake. So I think the bottom line is, yes, better to do it on empty stomach.
Okay. Ma'am, what is the minimal interval between thyroxine and PAN40?
Interestingly, any gap has been shown to reduce the TSH value. So minimum gap has to be about half an hour, but there have been studies done, for example, where they've given the PAN40 the previous night, PAN40, we are using brand names, where they've given the proton pump inhibitor the previous night. And even with that, it has been shown to reduce the TSH value. So there is some interaction between the thyroid absorption. Sorry, increase the TSH value, not decrease, increase the TSH value. There is some interaction between the usage of proton pump inhibitors and thyroid absorption. So I don't think there is any, in general, we would say keep at least a half an hour to 1 hour gap. Give the thyroid tablet first and give the PPI, say, before breakfast or half an hour before breakfast, separate it out at least by an hour or so. But remember that PPI taken at any time has been shown to affect thyroid requirement.
And most often we see patients in OP saying that they keep missing thyroid tablets because they forget to take it because that has to be the first thing which they have to do and they forget. So what happens to these type of patients if they skip and if they take after meals, is that okay? Or how do we, what do we advise them, ma'am?
Yeah, I'll tell you practically what I advise, and maybe Dr. Krishna will have a different approach to it. Nowadays, there are studies showing that you can take the thyroid tablet at bedtime, provided it's 3 hours after dinner. So in societies like ours, where we have a late dinner, it's difficult. But if you're going to finish your dinner by 6 or 7, you can take it at 10 p.m., provided you're not taking any other tablet at that time. You're not taking your statins or any other tablet. That's number one. Number two, for some women, we've certainly given the thyroid tablet 2 hours between meals. So between breakfast and lunch, or we ask them to take it in the evening. It's better. It's not as good as taking it on empty stomach in the morning, but it's better than missing the tablet completely for that period of 24 hours. You may not get the 60 to 70% absorption that you're going to get with empty stomach tablet, but you'll still get at least about 30 to 40% of the levothyroxine getting absorbed. So it's okay. It's okay to take it during the day when you remember. The way I counsel them is take it 1 hour between meals.
Okay. Ma'am, one more question. As we see different levels of thyroid levels in each trimester, even if the patient thyroid level is normal in the initial part of the pregnancy, it is advisable to repeat every trimester. What do you say about that, ma'am?
I think most of us, if the initial TSH value is very, very normal, like say 1.8 or 1.9 something, and low risk pregnancy, there's no recommendation to repeat it. If you've got values which are, say, 3.5, 3.8, I would certainly repeat it.
Okay.
So borderline values, no cutoff as such. Maybe any value that's starting to go above 3.5, I would consider repeating, particularly in higher risk pregnancies.
Okay. Okay, ma'am.
Dr. Jaishree, you were talking about the prolactin when it comes normal, you would still continue. So, for example, if they take longer time to conceive also, we will be continuing the prolactin because we have seen a lot of doctors giving an empirical cabergoline when they have an irregular cycles, and they say when it is normal, they stop. So what would you advise them as such?
No, this is completely only based on an elevation of the prolactin level, not an empirical trial at all. What I was talking about was you're doing your pregnancy treatment and the prolactin has come into range. You stop it, unfortunately, the prolactin will shoot back up. So don't stop it abruptly. Do a slow taper. Let's say you're down to once in 10 days or once in 2 weeks and your prolactin level is below 5, stop and see.
Okay.
If it goes up again, then you can, restart. But quite often, it comes into the range, okay, it's normal, you stop and then you continue with the fertility treatment, forgetting about the prolactin, and then it'll again shoot up and cause a delay in conceiving. That's why I said don't stop it abruptly. Taper.
I would not stop it for at least 2 years if there's a microprolactinoma.
No, this is in people who have just like a PCOS and borderline elevated prolactin, Krishna. Idiopathic.
Yeah, okay. So, in the sense that if there's a microprolactinoma, don't stop for 2 years at least. bring it down to a low normal. You can taper it down. You can bring it down to 1 tablet a week and leave them on it. But if you stop it, it's going to go up. Other indications, the data that supports the fertility there is sort of iffy, but I agree with what Jayashree says. At least keep it or keep the patient on, 0.25 milligrams once a week, and then take it off. Even if the patients, what I see is that when patients go on IVF therapy, for some reason, many infertility specialists stop the cabergoline, as Jayashree mentioned. I'm not so sure that's a wise idea, because there are two things. One is there is a clear link between clinical pregnancies and prolactin levels, in the sense that there is an altered endometrium, there is an altered implantation that occurs, that you may get your HCG up, but your clinical pregnancy and live births may actually suffer if you stop the cabergoline. And there has been no data that supports that says that cabergoline interferes with either implantation or by continuation of an IVF pregnancy. That data is very, very clear. So in that thing, I think continuing the medication is the right thing to do till at least the clinical pregnancy is confirmed.
So then another question in the chat box: should we do the test before taking the tablet?
Yeah, I'm just replying to it, and the answer is yes, but I'm just sending the reply.
Thank you.
Thank you,
One
ma'am.
more point in Jayashree, I just wanted to add, maybe you should comment on it. When you see these tumors that extend beyond the NOPS grade 2 or 3, one of the things that even gynecologists should remember is that there can be a co-secretion of another lesion, especially when we talk about it in our cases. But always get an IGF-1, or at least make sure, at least get an endocrinologist in the loop on that one.
Yeah, it's a good point. Yeah.
Okay, ma'am. Thank you, ma'am. Thank you so much. Thank you so much.
Thank you.
So
Yeah.
we'll move on to the next session, which would be an interesting panel discussion. And we are very happy to have Dr. Krishna Shishadri sir for moderating the next session, which would be on endocrine disorders in pregnancy. Sir is senior consultant from Apollo Hospitals, and sir is founder and chairman of Clinic Tech, which is a medical technology company, and director of Primer. Thank you, sir. Sir, you would like to introduce the panelists, or you want me to do it, sir?
I'm okay. You can introduce the panelists, and then I will.
Yes, sir. So we do have our panelist today would be Dr. Uma Kalyansundaram from Sundaram Medical Foundation. Madam is senior consultant in Department of Obstetrics and Gynecology. And we have Dr. Bharat, who's medical director and consultant endocrinologist from ARCA Center from Ananagar, Chennai. And we have Dr. Geeta Lakshmi, who's a consultant endocrinologist from Kamakshi Memorial and Pragati ENT and Endocrine Clinic. And we also have Dr. Tarakeshwari from Fernandez Hospital. Madam is senior consultant and head of obstetric medicine from Fernandez Hospital, Hyderabad. Thank you. Sir, you can start the session, sir.
Can you allow me to share the screen?
Yes, sir. Yes, sir. Let me stop it.
Just 1 second. Since Jayashree and Anjali have already spoken about thyroid and prolactin, I thought we'll do some other stuff, but actually starting with something that is very, very common. The most common endocrinopathy that you see in pregnancy today is obesity. So let me start off with the first one. And I'm going to keep this open, so I'm not going to really point out who to answer unless people don't answer when I volunteer. The other thing is we can also probably allow the audience to interact more frequently. I think we can live with some chaos. Can everybody see my slides?
Yes, sir.
Yeah. Okay, so here is a 31-year-old woman planning a pregnancy. Menses is regular but scanty, 160 centimeters, 105 kg. I haven't put the BMI, but you can be certain that this is over 30. The waist is 112. The TSH is 3.1, HbA1c is 5.4. Hemoglobin is 10. She complains of fatigue when she wakes up, and she has noticed some snoring. Okay. So the first question is, opening remarks, opening thoughts. Let me start off with the obstetricians. Do you see this in your practice? What are your concerns? What do you do, and what else do you measure?
So obviously, I am Tara, and greetings from Fernandez. Obviously, this is a morbid obesity, BMI more than 40. Then she has anemic also. Her hemoglobin is 10, and she has something like obstructive sleep apnea. So definitely she will be tired. And other investigations I would like to is I always confirm diabetes by doing an oral glucose tolerance test, and HB variant analysis also we would like to do with anemia, and measure her blood pressure, and ask her about her nutritional status also, sir.
Okay, I'm just going to give you these values. Her TSH is normal. Her hemoglobin is fine. There is no hemoglobinopathy. What else did you want?
So she's anemic,
All the
sir.
others are normal.
She's anemic and she has got obstructive sleep apnea. I would like to do the sleep studies, and I would like to refer to the nutritionist and an endocrinologist to optimize before her
She
weight
wants to
before
get,
planning.
the first question is, she wants to get pregnant. Is it optimal for her to get pregnant? So
No,
that's
sir,
first.
not.
Okay. Okay.
Because she's at
So
more than 40 BMI. Ideally, we will take the help of the nutritionist as well as the endocrinologist, and the options of therapy, whether we need to understand about her and medical therapy versus bariatric surgery. First is nutrition, sir. Optimize her, the lifestyle.
So before we go there, let's get some opinions on what is the likelihood that this woman will anyone can come in, of course. Is what is the likelihood that this woman will conceive on her own? If she conceives, what is the likelihood that she will complete a pregnancy, and what are the complications that one would expect in pregnancy? Maybe Dr. Uma, you want to take this?
Yes, sir. So this is class 3 obesity. So she's most likely having a reduced likelihood of a successful conception. Scanty menses, she has regular menses, though scanty. Possibly she may have anovulatory cycles. And also because of her morbid obesity, there's a higher risk of complications during pregnancy and birth. So definitely the impact on conception would be due to the various hormonal imbalances she's likely to have. There will also be a reduced fecundity in obese patients, and poorer egg quality has been noted in these patients. So definitely there is a concern if she would conceive naturally with this sort of obesity and without having been treated for it.
Even
Whether
if she has, let us say, even if she has normal menses, is there a reduce? Is there an increase? Is fertility down in these patients?
Yes, sir. Yes, sir. There is a reduced fecundity in these patients. So about 4% for each unit increase, above BMI of 29 kg per meter square. So definitely there is reduced fertility in these patients.
Geeta is not joined, is it?
Also, there is a poorer egg
And there's,
quality in these patients.
Well, Geeta, I can't see you. Okay,
yes,
Bharat,
yes,
if this
Yes, sir.
patient
yeah,
were
I
seeing
mean,
you, what would you measure? What are the things that you would do? Well, what would you do in this patient? Let's say this patient was sent to you. Bharat?
Yes, sir. So I think gynecologists have already pointed out certain tests which they need as the blood glucose level and all. But what I would like to see is entire the I would like to go through her history, her family history, because we need to see in such a kind of morbid obesity, we need to assess her cardiometabolic risk before she plans for pregnancy, because such kind of patients already having a sleep apnea will have a greater risk of cardiovascular problems, especially atherosclerotic cardiovascular diseases. And so I would like to have a cardiometabolic assessment for this patient, including the repeat profile, the
HbA1c is
upper
normal, coronary artery calcium score is 0, no evidence of ECG disturbances, NT-proBNP is less than 60. What?
HSCRP is also normal, sir, I think.
HSCRP is undetectable.
So you are giving a very,
Right.
very ideal situation, sir. But that doesn't happen in many of our patients.
No,
Sir.
I'm just trying to stay straight and narrow into this pregnancy bit. So,
Yes,
right.
yes, sir. So before planning, before
So
planning pregnancy, I would
I have
always,
one question for you, Bharat.
yes, sir.
So do you go by the BMI, or is there anything else that you that in or do you just use the waist, or are there other measures that you use nowadays in practice?
No, one is the waist is to
Quantify
height.
obesity.
Waist is to height ratio is another important parameter that we are taking into consideration so nowadays. And second thing is the neck circumference. So I think waist to height ratio and neck circumference is another important parameter. I think in Indian patients where waist may not be, we may not be able to measure waist always because of reasons. Even a neck circumference would be a good parameter. Even checking for signs of insulin resistance like acanthosis nigricans, all these things will always give us a hint. Apart from checking the routine BMI, because BMI always doesn't reflect the overall picture in many of our Indian patients. We know that it is we are having a lean fat phenotype.
So just to supplement for those who are new to this, we no longer go just with the waist measurements, because these can be quite misleading. And the waist by height is actually sex independent, and any
Yes,
value of waist by height more than 0.5 indicates
0.5.
that this patient has abdominal obesity. Geeta, I'm going to ask you: do you do so? We don't. So this hip and waist ratio, somebody is
Yeah,
Arati has put in this. We no longer do that
do that. Yeah,
in practice, as it is quite misleading.
yes.
Geeta, do you do a body composition analysis in your clinic, or what do you do?
Sir, that would be, it's slowly coming up in a bigger way because the body composition analysis not only talks about the overall weight, but it also talks about the visceral adiposity, the body fat distribution in various areas. As already everybody has pointed out, it not only gives us an overall index of weight, but it also gives us an assessment of the cardiometabolic risk as well. Because when you know you have a increased amount of visceral fat adiposity, then you're going to look at the other parameters at a very with a magnifying
So you
glasses.
think
I
it's
think
worth an investment?
yes, yes. Slowly, it's coming up in a bigger way, but still, it has to be established. It's not up to the mark with a gold standard.
Right. So
Just one thing to answer.
so Tara K has asked, is it how reliable is body fat estimation? Please put your questions as they come, and we will answer them as
Yes,
we go on. Right.
body
We do a
composition
much.
analysis, actually, that is coming up in a big way, sir, now. Generally, I use it in my clinical practice when the patient is put into a lifestyle modification program, especially with either injectables or with only with lifestyle modification. The patient wants to reassess them because the BMI and the weight always doesn't. It's not a sufficient indicator to assess their progress. So in that situation, I repeat the body composition analysis after a period of time, like 4 to 6 months interval, to just show them how they have fared well during the time of the period of intervention, sir.
Okay. Just for everyone to understand that there are so the body composition analysis is actually a poor substitute for the DEXA, which is a scan that
Yes,
most of
sir.
you are familiar, where we do a osteoporosis measurement. So this is the DEXA is the gold standard for measuring fat. And if you don't have access to a DEXA and you're interested in making some money in your clinic, you can invest in a body composition analysis machine. These are anywhere between 3 and 10 lakhs, and give you more information than you ever need in your practice. And most of this information is used by pseudo influencers on Instagram to make people's life miserable. I pretty much use a waist by height, and if the body mass index is more than 23 and the waist by height is more than 0.5, you probably don't need any further measurements. But if you're really interested in impressing the patient, please get one. Uh, one more before I jump on, Geeta. Is there any? If I don't have access to a sleep study, are there a bunch of questions that I can ask to find out if this patient is at a high risk for obstructive sleep apnea?
The Epworth questionnaire can be used. So this is a very simple subjective way of assessing the prevalence of sleep apnea and the severity of the sleep apnea as well. It's an indirect measure, though it's not a very accurate one. But at least I think even without doing a proper sleep study, I think we can have an idea of how severe the obesity is going to contribute to the morbidity.
And
So there
the
are
stop band thing, score also can be used.
Yes.
the OSA stop bank is probably a little more specific.
Perfect.
Can you just list out the components, Bharat, before I rush?
Yeah, stop band, this thing questionnaire, it shows mainly do you snore loudly? Yes for snoring, and O for like feeling of tiredness. Sorry, it's a tiredness. T for tiredness. O for I think
O is obesity, S for
obesity. S for
snoring.
snoring. T for tiredness, and B for BMI, age, and neck circumference.
So if you're a woman, if you're
G
on
is
blood
the
pressure
gender.
treatment, if
Gender.
you're a man, if you're on blood pressure treatment, if you are snoring, you wake up feeling tired, all of these carry 1 point. Please look it up. It's a very, very simple thing you can do in your
Simple.
ring, and it can help you. If the score is more than 5, it gives you a high index of suspicion of obstructive sleep apnea. You want to get a sleep study, get an outpatient sleep study, and nothing more is required. We measure what is called the apnea hypopnea index. But let's get back to this patient. So, ma'am, I sent her to a nutritionist. She put her on 6 almonds a day, gave her a low calorie intake. Now, 1 month later, she has not gained weight, but really nothing else has happened. So I'm just fast forwarding to all of you. How many of you refer your patients for pharmacotherapy? One, do you think pharmacotherapy is useful in patients planning a pregnancy? Well, there's a lot of data that shows, I'm not getting into it, there's a lot of data that shows that weight loss improves pregnancy outcomes. In the Dutch lifestyle study, you will see that 15%, and the magic number seems to be 15%. A 15% weight loss improves IVF outcomes, a 15% improves obstetric outcomes and other things. But just to jump to everybody's question, Dr. Tarakeshwari and Dr. Uma, how many of your patients would you are on pharmacotherapy?
I don't have any patients on pharmacotherapy yet, sir. I've had patients who have undergone bariatric surgery or have been referred out for bariatric surgery, but not yet pharmacotherapy. So I have no personal experience with this.
So metabolic surgery is indeed the most effective weight loss therapy ever discovered, and it still has its role in practice. It's sort of being overtaken by pharmacotherapy. Dr. Tarakeshwari, your comments? Ma'am, I think you're on mute.
You're on mute.
Can't hear you.
With pharmacotherapy becoming more popular, probably along the way, we will see more patients had before they come to us. They've already had pharmacotherapy and then come back to us for pregnancy, sir.
Bharat, you want to jump in? How many of your patients planning pregnancy are on pharmacotherapy?
Now, in the last 6 months to 1 year after the introduction of the newer GLP-1 molecules, and which has created a lot of hype among everyone. Actually, I am getting a lot of referrals from obstetrician colleagues asking for a weight reduction medication before they subjected for an IVF, before planning for a pregnancy. So I think that those referrals are increasing quite often. Daily, we are getting at least 1 or 2 patients who come on their own or referred by their obstetricians for a pre-pregnancy weight loss with the pharmacotherapy. So I think that's coming up in a big way, and many patients are. I think that is the time when we can motivate them to the maximum extent of weight loss, and they are willing to do that also.
Geeta?
Sir, can you hear me,
Sir,
sir, now?
Yes, I can hear you, ma'am.
Yeah,
Let,
so
let Dr. Tarakeshwari respond and then
yeah.
we get to Geeta.
The similar experience I said, sir, and we refer to the endocrinologists. So we don't have experience with those on medical therapy and coming to us. Most of them are on bariatric surgery and came back. We have endocrinologists, sir, in all the units, so we refer to them. Thank you.
But I don't know if you remember Dr.
Right.
Tarakeshwari. Actually, Dr. Evita was a person who first gave me a talk in this country. So
We
very,
all
very
know you,
long
sir.
time. Yes.
Yeah.
So please come give my regards to ma'am.
Sure,
Geeta?
sir.
Yes, sir. Sir, actually there are a handful of patients. I think definitely they do very well when they, as you said, that 15% is a magical number. But even like 10% weight loss actually does a huge change. It's become a huge transformation in their reproductive journey, I feel. And especially with the advent of this GLP-1 and GLP-GIP, I think there's a huge change in that aspect as well. So I think our classification should also include subfertility as one of the criteria for adding pharmacotherapy for obesity, whenever there's an elevated BMI along with subfertility, I think we should consider.
Before we get into the pharmacotherapies available, just to answer this question, nutritional deficiencies indeed very common with metabolic surgery. Must look for B12 and other deficiencies. So really, somebody in metabolic surgery should be under the care of a person who understands nutritional deficiencies. But I'm not going to go into metabolic surgery today. Let's move on to the pharmacotherapy. The important thing to remember is that pregnancy in the presence of pharmacotherapy, GLP-1 RAs or tirzepatide or the other incretins and polycretins is not recommended. Meaning that if you can indeed reduce the weight, but for example, pre-IVF or a pre-planned pregnancy, an 8-week washout is recommended. Although we can discuss this that we have enough of number. Even I have a couple of Ozempic and Mounjaro babies. We can talk about it towards the end of this discussion. But important to remember that while we are talking about pharmacotherapy, the current recommendation is that given the fact that in animal data there have been issues, not in human data, that getting pregnant on one of these drugs is not recommended. Having said that, getting the patient's weight down and then planning a pregnancy is something that we talk about. So, Geeta, can you summarize the drugs that are available? And before that, just why is this 15% number big? Let me give you this simple number to remember. If you lose 15% of your weight, you lose 30% intra-abdominal fat, which means you lose 66% of intrahepatic triglyceride, which means you pretty much lost insulin resistance. That's why this 15% works beautifully. Geeta, what are the drugs that you would use?
So right now we are concentrating only on two agents. That's primarily about the GLP-1 agonist and also the GLP dual analogs, that is the GLP-GIP1. And that will be the tirzepatide, which is the one which with maximum weight loss efficacy right now, and followed closely by the GLP-1s. And in top of GLP-1s, the list, it would be semaglutide, which is available as an oral preparation and also as a subcutaneous preparation. So the oral preparation is the Ribelsis, as we commonly hear about, which is the daily to be taken oral GLP-1 RA and the only oral GLP-1 RA. And coming on to the sub-Q semaglutide, that it would be the Wegovy or the Ozempic. So Wegovy is the one which is approval for the management of obesity. And the weight loss potential of these agents is somewhere around, see, with the semaglutide oral, it was only around 5 to 10%. Now we have agents like tirzepatide, which can at least achieve 15% weight loss. So which is almost, we are close to that magical number.
Bharat, what are the side effects and what would you look for?
Yeah, mainly before starting the agent, we should be careful about when to start and how to titrate the dosage and who are the patients who are really uh, candidates for those things, because the patient should be first motivated to have that injection regularly. The cost of the therapy should be borne by the patient in Indian setting. And then, as Sir pointed out, the patient should not become pregnant on these injections. So there should be a gap of at least 2 months stopping the injection and then planning for pregnancy. So all these things, the patient should be careful about that. And she should also be told that sometimes she may get symptoms of predominantly GI symptoms, because these drugs mainly work from the GI aspect. So GI symptoms will be there for the patient, especially nausea. Some patients may have vomiting. Some patients even complain of frequent bowel movements after taking the first dose of injections. So these should be told to the patient, and patients should be asked about the family history of medullary CA thyroid, family previous history of any pancreatitis episodes, anything like that, before we screen them. If the patient is a full-blown diabetic, I would also screen them for a retinopathy before putting them on a GLP-1 analog. So there is a checklist which we should follow, and after counseling them carefully only, we should be starting them on the GLP-1 analogs and their combined incretins.
Before I bring in the obstetricians for the complications to expect during pregnancy, just quickly also to warn people that a rare condition called non-arthritic ischemic aortic neuropathy has been reported with these drugs. Every pharma company will downplay it, but this is a real thing. we usually get a fundus photograph on all our patients and have the cup disc ratio measured. If it is less than 0.3, we ask for an ophthalmology opinion before we go out. Now, Geeta, will you recommend termination of pregnancy if they get pregnant on the drug?
So far, there have been no recommendations in this regard, but only thing is if they are going in for
What will you
assisted
recommend?
reproduction or planning pregnancy, it would be ideal to stop at least 6 to 8 weeks
Hey,
before.
you didn't stop. I mean, the very interesting thing and bad news for the IVF specialists is that interestingly, when started on these drugs, there's a greater degree of spontaneous conception. Fantastic data that has come out showing that when you lose weight, irrespective of the mechanism of weight loss, there's a greater degree of spontaneous conception even in patients who have actually been referred to you for an IVF. So if you're really a smart IVF doctor, don't refer it. But let us say this patient did get pregnant while you're on the drug. Would you stop the drug? Will you ask them to terminate the pregnancy?
No.
No. So in fact, there are sufficient number of Ozempic and Mounjaro babies that are wandering around the world, including a few of mine. So we will go. So I'm going to bring in the gynecologist today back into it to close this discussion, ma'am. If a pregnant woman with, let's say, a BMI more than 28, if a woman gets pregnant, what are the things that you are worried about from an obstetric point of view during the pregnancy? What should you be careful about?
Maternal risks are many here. She's more at risk for gestational diabetes mellitus. She's more at risk for developing preeclampsia, frequent infections like urinary tract infections. Also, with higher classes of obesity, she has had higher risk of VTE. So these are the things I would look for, keep in mind during pregnancy. There are fetal risks as well, and one of the main things would be congenital anomalies in patients with morbid obesities, especially cardiac and neural tube defects. There is a risk of macrosomia in the baby, therefore there is increased risk of birth injury due to shoulder dystocia, and later on childhood obesity in some of these babies going on. Preterm birth is a very important risk in these ladies. Then later, also stillbirth. One of the main complications would be stillbirth. Since there are many times we might miss fetal growth retardation since we are unable to assess them clinically. So we might miss fetal growth retardation if we do not follow up with regular scans. So stillbirth is a very important complication in these patients. As for labor and delivery, they are more likely to have a prolonged labor, operative delivery with the risk of anesthesia, more at risk for postpartum hemorrhage. So, and again, they would, for a postpartum, their breastfeeding is a big challenge for obese women. So these are some of the things I would keep out a watch for and keep counseling them throughout their pregnancy, labor, and postpartum. So,
Tarikesh, anything to add?
No, sir, almost covered, except increased risk of spontaneous miscarriages, mid-trimester losses is one to be added. And only I can say, sir, we have a body positive clinic. We call them more than 40 BMI. One consultant obstetrician takes care along with the nutrition, physiotherapy, and endocrinologist. And about 50 to 60 BMI women, the special surgeries while doing the cesarean section, not everybody can operate on them. You need to have the experience. And we use the Alexis retractor, sir. Most of the surgeons use that retractor. We use it for the high BMI women. Only these points I wanted to add, sir.
Just to add a couple more things. One is there are offspring risks. There's a greater risk of diabetes as well as, importantly, very interestingly, that there is a transgenerational imprinting of this, which means that fertility is reduced in the very interesting animal data showing that there is a 3-generational transmission of subfertility in offspring of obese rats. So I'm certain that there is some truth to the whole thing. The first interesting large series looking at patients on whom these drugs were stopped and then they subsequently got pregnant showed a higher incidence of preterm, but nothing really else. What do you look for in when they conceive with these pharmaceuticals? Your guess is as good as mine. We really don't have any fetal markers. We don't have ultrasound markers. We just have to hope and pray that they get well till the statute of limitations for suing us stops. With that, I'm going to move on. Unless there are any burning questions or comments from any of the panelists or anybody else, I have two or three more cases, but I think we have a hard stop at 4. Is that right?
Yes.
Okay, so let's go on to the next case. We'll do this very quickly. The reason I put to this case is for us to understand this new entity that we are talking about. I'll present this patient and anyone can take up again. Here is a 28-year-old woman, presents with the following testing done just at early pregnancy. She is G1, 6 weeks. Mother has diabetes. Height is 155 centimeters. Weight is 80 kgs. She has a fasting glucose that's 98, a postprandial is 128, and an HbA1c of 5.6. Opening thoughts. Again, I'm going to let the obstetricians come in first, and then I will allow the endocrinologist to pitch in.
So she's a
What are your
primary gravida and with a family history of diabetes. So she requires screening early in pregnancy at the booking visit. Her BMI is also close to 36 approximately. So definitely her sugars have to be tested, but I would rather prefer a glucose tolerance test in these patients than directly going in for a fasting and 2-hour PP. HbA1c is not really indicated in pregnancy, sir. So my first thought would be she should have had a oral glucose tolerance test
at 6
rather
weeks?
than a fasting and PP.
At 6 weeks?
Yes.
No, can I,
Dr.
sir? Yeah.
Yeah.
Sir, I consider it as a early GDMs because we really have a fasting already 98 and a HbA1c of 5.6. Latest studies show that A1c 5.7 and association of GDM is high. Maybe this is the entity I think, sir, is coming up. So I would like to put her on 4-point monitoring and diet right from here, sir, because her fasting is 98. But OGTT we do only after 12 weeks. So not before 12 weeks. So I consider it as maybe she's a pre-gestational one who was not tested and we call it as early GDM, sir.
Okay, I'm going to ask the endocrinologist and then I'll come in class. Bharat, your comments on this?
Yes, sir. Actually, this patient classically, as you have described, they fit into that the paradigm shift in the management of or in the diagnosis of gestational diabetes, what has been going through because of various studies which have come up, including the TRIDES data which has been there. So the fasting sugar of 98 and the HbA1c of 5.6 percentage and a higher BMI. So it's a cluster of high risk factors. And any A1C of even above 5.4% during the first trimester, there is a high risk of this patient going to a full-blown kind of a gestational diabetes when you screen them at 24 to 28 weeks. That's what the data which involved our Chennai patients and Pondicherry patients have shown. So based on that, I would consider this patient as a high-risk one, not like a reverter kind of thing, but probably a progressor category of early gestational diabetes.
Geeta?
Sir, I think we have to start looking at these values earlier because we have a lot of PCO women and obese women who are becoming pregnant. And because of this, I think the prevalence of the so-called early gestational diabetes has gone up significantly. So any fasting blood sugar which is less than 92 milligrams per deciliter. So this is the new cutoff coming up. So anything less than 92 milligrams per deciliter, definitely in the early trimester, I think points towards a future GDM. And also, the famous Toboggan study from Sydney has told that at least 80 to 90% of these women who came with this kind of values are ending up with GDM later. Even without a proper OGTT showing GDM, they develop the complications which are suggestive of GDM. So I think definitely we should be starting to look at these women earlier and intervene earlier.
Okay. Is it okay? Let me also throw in my two pieces on this. First is I think a very interesting set. In the past, we would wonder whether this is diabetes in pregnancy or gestational diabetes, right? But so we don't look at this anymore. So when you see this kind of values in early pregnancy, you really want to think about one, early converters, second, rapid progressors. And interestingly, the reason I threw in the HbA1c is because we now have data from the STRIDE study that show that anyone with an A1C more than 5.2 to 5.3 is someone that is almost a rule in. It's no longer a rule out, in the sense that if it's less than 4.8, then this person is not going to progress. But clearly we have a lot of data that is coming out showing that an A1C of 5.2 and above in Indian population, this is a study, Ponuswamy Saravan's data, looking at Kenya, India, and others, that is beginning to show patients that these are patients who require to be either first started on diet and exercise, and there are some people who would say that many of them would require early therapy based on their continued values over a period of time. But I thought I didn't want to get into a GDM discussion today, but just to sort of highlight people that this space is changing. Somebody talked about Dr. Sesha's theory. In fact, very interestingly, Dr. Sesha is now talking about if the glucose is more than 140 sartan and metformin. I think he has. I had some very interesting discussions with him about 3 weeks ago. The Tamil Nadu RSSDI is doing some work on this, and I think Dr. Sesha has already succeeded in talking about starting metformin in some of these patients. We could have a great discussion on metformin, but that would mean that people will fire that the rest of this hour is going to be lost on it. So GDM is another whole discussion another day. I just wanted to get this little interesting piece of information into everybody that don't dismiss HbA1c in pregnancy. We now have data supporting it, that early glucose control is probably is in at least some of these patients may be required. In some of this, it's an overkill. I remember also that even GDM therapy in many ways is an overkill, because you're treating, those of you who heard me last time speak at Trento, I talk about clusters in diabetes, that it's time to start looking at clusters. I do two things. I also look at the triglyceride glucose index. If the triglyceride glucose index is not very high, then I wouldn't be so aggressive about some of these patients. So we can do that another day, but let's move on. Any comments from the other panelists or anybody before I move on to
So
further
I
interesting? I
would
just thought I'd
start.
throw this in.
I would start management with this HbA1c, sir, but would you think it would help? Would you use it for follow-up HbA1c? I
No,
hear many
absolutely.
obstetricians are following up with only HbA1c, which
No,
I
don't
wouldn't.
follow up with HbA1c.
No, I wouldn't.
Use it as a cutoff.
Yes, sir.
HbA1c is not
Only for
recommended
guys.
follow-up. However,
Definitely.
and remember, there's no role of HbA1c in the second or third trimester for diagnosis. We're talking about someone who's just pregnant within the first 12 to 14 weeks, and A1C can of 5.2 or above is a rule in many ways. Okay, there is a rule out also around 4.6 or 4.8.
4.8.
Some people are looking at lower numbers like 4.2 or 4.3. But
4.8 is
4.8 is rule out and 5.4
5.4
is rule in.
in some communities even lower than that. Very
Yes.
interesting data that you see in the supplemental table of that entire study. Okay, so I'm going to move on. If there are no questions about it, we can do a GDM another day. Let's go to this patient. Here is a 26-year-old presenting with recurrent attacks of hypoglycemia. She was diagnosed with GDM in week 26 and has been on insulin. In week 34, she developed a headache, was brought to the ER with a glucose of 40. Insulin was gradually reduced and stopped. She was discharged home on no insulin. Again, she presented at week 36 with spontaneous hypoglycemia. At the ER, the CBG is less than 40. She has mild hyponatremia. Bicarbonate is on the lower end of normal. Creatinine is 0.8. They drew a cortisol on her, and that was less than 5. I'm not going to discuss pregnancy cutoffs or cortisol. So this is the value that we have. Initial thoughts from the obstetricians, and then I'll bring in the endocrinologists.
Sir, I feel it is not a GDM-induced hypoglycemia. Definitely, it doesn't go like that. So I will always ask my endocrinologist to help me. Dr. Santosh and Dr. Raman.
Dr. Uma.
I pass this too, sir.
Okay. Geeta, you want to take this up?
Yes, sir. Yeah. So, recurrent episodes of spontaneous hypoglycemia in a pregnant woman, and with the clinical, with the biochemical markers of hyponatremia is definitely, and it's definitely suggestive of a central cause going on there. There is a cortisol insufficiency, and in pregnancy, the most common reason would be a postpartum hypophysitis, I would consider, because which is very common at the third trimester and the immediate postpartum. So, and to be supported with the lab investigations given here, the cortisol values are usually the baseline values are much higher in pregnancies, though the cutoffs have not been clearly established. So even a cortisol value of 4.6, even without an ACTH stimulation, is definitely suggestive of hypocortisolism. The one caveat here, there is a low FT4, but it is not reliable because it's in the third trimester of pregnancy.
Okay.
So
Right.
I would consider a postpartum hypophysitis.
But
So
she's antepartum period. She's only 34 weeks.
Sorry, not postpartum. So I would consider a hypophysitis. Sorry.
Hypophysitis.
Yeah.
Sir, is it stuck?
It looks like that.
Yeah, I think some problem from sir's side. Let me just check. Give me a minute.
Yes.
I just want to share with Dr. Bharat, we are a part of STRIDE study.
Yeah, madam. I saw that actually, and now
Yeah.
I am able to recollect that this thing when I went through the study.
Thank you. It's really a wonderful study. Sir
Yeah,
has
yeah.
come back.
Actually, it's a wonderful study, madam. It's a wonderful study, and it's a very novel this thing, I would say. Like it gives us a great insight into our spectrum of patients, because we, instead of just compartmentalizing them, it gives us this thing, graded.
Sir is back.
Sir, you're not audible, sir.
You're on mute.
Mute, sir.
Can you hear me?
Yes, sir.
Yes, sir.
Okay.
Yes, sir. Yeah.
I'm sorry about that. Sorry. Power cuts are fairly rare here. I live very close to the chief minister's house, but it happens. Okay, so not postpartum. This is peripartum. So the first thing is to not call it postpartum. It is peripartum hypophysitis. But remember, just to tell people, hypophysitis is an inflammation of the pituitary gland. And in the olden days, we used to think it is only peripartum. But remember, it can occur in the ICU. It can occur after injury. It can occur during critical illnesses. It's very, very common. And maybe towards the end of the discussion, I will also debunk the whole theory of Sheehan syndrome, which we can talk about. But to go back with this particular patient, so as Geeta Lakshmi said, this is central. Therefore, we ordered an MRI. Remember, an MRI is safe in pregnancy. And Bharat, you want to take the MRI? Can you see it?
Yeah, MRI without gadolinium done is pretty safe. We generally, if at all it is required, we can do it in the second trimester and without contrast, without giving contrast. And I think this patient also had undergone an MRI, sir.
Sir,
I think the MRI.
you have to share your screen, I think, sir. We can't see your slide.
Oh, okay. 1 second. See me? See it?
Not yet, sir.
Just waiting. Yes, sir.
Yes.
So as we can see that this is
Sorry,
a MRI plain thing here, sir. The T1 weighted image of the MRI is showing an intense enhancement of the pituitary gland, a uniform and intense enhancement of the pituitary gland. Even I think the stalk is also involved in that, though we are not able to see it very clearly. The stalk is not delineated in this cut, and with a clear cut margin, like not involving the optic chiasm. So this is one of the classic pictures, I would say, of a lymphocytic hypophysitis, which is common in the third trimester of pregnancy. So among the 5 different hypophysitis, lymphocytic one is more common, and during the third trimester of pregnancy. So this patient, from the clinical as well as from the radiological picture, it fits into the scenario of lymphocytic hypophysitis happening during the third trimester.
So what will you do for this patient?
So the management wise, at least this patient has to be on corticosteroid replacement. One is because she has a low cortisol and she has a low sodium. The second question is whether the hypophysitis, whether we will give anti-inflammatory dose of hypophysitis steroids for the management of hypophysitis is another question, because that can sometimes have an effect on the lung maturity also. So since the patient is at the 36 weeks of pregnancy, so we should also consider giving an anti-inflammatory dose also. But definitely the patient should be on a replacement dose of steroid, especially hydrocortisone. Initially, as an IV injection, if the patient has come to ER, maybe tapering down to a physiological dose of around 15 to 20 milligram per day of hydrocortisone. So that will be the line of management for this patient. And using the anti-inflammatory dose of steroid is subject to the discussion how the patient is going to be on the follow-up.
So this patient may typically present postpartum without any of these symptoms as a non-consumption.
Sir, your audio is breaking, sir.
Sir,
Krishna,
not
sir?
clear, sir.
Excuse me, sir. Your audio is breaking, sir.
In fact, in Tamil Nadu and other unstable connection. Yeah. Let me just speak now without the video.
Yes.
So in Tamil Nadu and other places, can you hear me now?
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay. So remember that Kashmir is the only place in the country which is still has domiciliary deliveries, and that is why it has the highest incidence of Sheehan syndrome. In the rest of the country, the most common cause of postpartum non-resumption of menses is actually a lymphocytic hyperphysitis. Many of us would argue that this is indeed that even Sheehan syndrome is just a manifestation of lymphocytic hyperphysitis. So just for people to be aware that if you see this, and in this particular patient, Geeta, you want to go back to the thyroid, would you now replace the thyroid on this patient irrespective of the TSH?
I think better safer than
Geeta?
sorry, sir.
Yes, sir.
So you're able to hear me?
Yeah.
Yeah. I think there's no harm in replacing with a small dose because usually central causes require a very, very small dose of thyroxine. So I don't think there is a harm replacing with 25 to 50 micrograms of levothyroxine for this patient, especially in a pregnancy third trimester where we are not able to assess the exact value.
Okay. We have 10 minutes, so I'm just going to do one last case, and that is to sort of, to point out the problems with doing empiric therapy without understanding the entire condition. So it's not meant to be preachy, but it's a good case. It's a real case. So here is a 32-year-old woman who presents with worsening of headaches and decreased peripheral vision. She's 12 weeks pregnant. She's initially evaluated subfertility, found to have a mild prolactin elevation of 56. They thought this was just prolactin elevation PCOS. And of course, they started, and a TSH was obtained. It was 2.6. She was started on cabergoline. There was a resumption of a few cycles, but no conceptions. Then she went through an IVF protocol. They stopped the cabergoline during the IVF, just like how I pointed out during the discussion with Jayashree was involved. Then the pregnancy is confirmed. Then from week 8, she complains of progressive headache. The prolactin is done, which is found to be 170. She's restarted on cabergoline. But then she comes back to the emergency room with severe headache, and now she says that her peripheral vision is gone. Who wants to take this?
Sir, I'd like to go for this question.
Yes.
So this is one common thing which we all of us see in our OPD practice on a daily basis. Whenever a patient comes to us with an elevation of prolactin, I think there are multiple things that needs to be ruled out. Even if the patient comes with a subfertility and this prolactin might be the reason, I think there are multiple things that needs to be ruled out because prolactin is a hormone which has a lot of influencing factors. So we can rule these out. The first thing would be to do rule out offending medications which can cause mild hyperprolactinemia.
Geeta, can
And the
can
other
you
thing,
go on with that, because
sorry.
I think Jayashree is already in a full talk on prolactin.
Yes,
So
yes,
just
sir.
move.
Yes, sir. Yeah, okay. So, ruling out offending medications, any mild PCOS, and after that, I think it is better when we go in, when we are seeing a patient who is planned for subfertility management and evaluation. I think it's better to do an MRI at the start, because these kind of patients, when you initially miss out on imaging, many a time these patients are started on short-term cabergoline, and once they see a normal prolactin, the medication is stopped. And finally, the patient gets conceived because of the normalization of prolactin, and they come back with these kind of scenarios at the later part of this thing.
Can someone
So
have
I
a
think
very large prolactin secreting tumor and still have a normal prolactin or a slightly high prolactin?
yes, that can still be there because there's something called as hook effect. So it definitely needs to be ruled out. So that's why I told at the start there are multiple factors which needs to be considered before straight away starting a patient on cabergoline.
Okay, right. So here is in this particular patient, and just for everyone, if you see a macroprolactinoma today, a large tumor and the prolactin is elevated, please get an IGF-1 along with it, because we now know that there are multiple instances where patients have prolactinomas that are very large, high prolactins, and they almost invariably, not almost, but a significant number of them will have co-secretion of growth hormone, which is acromegaly. They go together, right? Just to go back to this patient, just to figure out, this is what she came back, and an MRI was ordered, and this is what the MRI showed. Bharat, you are the MRI expert.
Sir, actually, this MRI is showing SLR and a mass lesion with a enhancement, with a peripheral enhancement, rim kind of an enhancement, and the mass lesion is touching the optic chiasma on the right side, and there is a slight paracellular extension also, maybe of NOS grade 2, because it is just abutting the internal carotid artery on the right side in the cavernous sinus. So probably a NOS grade 2 of macroadenoma with a peripheral enhancement, and then supracellular as well as the paracellular extension. So as Sir pointed out, the two important aspects is whenever we do a prolactin and we find it to be high, it's before as Dr. Geeta Lakshmi pointed out, we rule out all the other causes for hyperprolactinemia, and when we conclude that this is a pituitary cause of hyperprolactinemia, we should always evaluate other pituitary functions also, including a complete thyroid profile, a free T4, free T3, a cortisol, IGF-1, everything has to be done, because an isolated big prolactinoma can have suppressive effect on the other hormones, and they can co-secrete IGF-1. Even there can be a portion which can be a non-functioning gonadotropic adenoma can also be there, co-secreting all these hormones. So it's always good that we do a complete pituitary panel. And if the patient is planning for pregnancy, even it is better to do an MRI pituitary, because many times there is a concept called high dose hook effect, where very high levels of prolactin, more than 10,000, 20,000, can be falsely showing a normal value because of the assay methodology, because of the competitive binding in the prolactin assay. So this is probably one of the important take-home message that I want to give.
And remember that TSH is a good screening test, right? But when you suspect a medical problem in endocrinology, you always measure hormone in pairs: estradiol, FSH, cortisol, ACTH, free T4, TSH. So always endocrinology hormones like to go as couples. Don't separate them out, right? With that, I know that we are 2 minutes to this thing. I'm going to ask Dr. Uma and Dr. Tarakeshwari if they have any other comments, and then maybe open it up for questions, and then Dr. Kundabi and Geeta, you can
So
take this to a close.
hyperprolactinemia is something we usually detect when a patient comes for a subfertility workup. So the small increase is 56. We wouldn't think of a very high increase. But would you still suggest MRI for these patients as well, Dr. Bharat?
So if I see an elevated prolactin and I can't explain it,
Okay.
drugs are the most common. By the way, Pandy. Everyone's on Pandy. Please stop doing Pantoprazole is not mitai. So then you will see drugs are the most common. Repeat it. If you can't explain it, get an MRI, right?
Good. Got it.
And that's a very, very important lesson to learn because the hook effect is very, very common. Second is uh, do not dismiss it as PCOS related. I think that's when you see bulks and bulks of prolactin, many of us dismiss it as PCOS related. Don't do it. Any other questions or comments? Okay, if that is there, then I'm what serum prolactin such as MRI in otherwise asymptomatic infertile women. Okay, if somebody is asymptomatic, right, then a mild prolactin elevation up to 60, I would check if there's a problem with the bioassay, meaning so you can get a MAC. There are varying forms of prolactin that are secreted. Is it important? We can actually do by measuring what is called the macroprolactin levels. If the macroprolactins are elevated, then I would not do anything about it. But if the patient has irregular menses and the prolactin is elevated, I will work it up to completion. And just to say, please don't do X-rays. They will only detect if the tumor is very large. The most cost-effective way to practice medicine is to do the most appropriate thing first, right? I think that is the message that we should probably carry.
I think an infertile woman who is planning, you are thinking that prolactin is the reason for the subfertility. It's worthwhile going for an MRI if the prolactin is around even 50, 60s. Because once the patient is pregnant and if she comes up with this kind of an issue, we'll be in a difficult situation to handle.
Yeah.
And MRI is far less expensive than the kind of investigations that fertile women go through in this country. So I think we should be that amount of penny pinching we should really not.
Yes, sir.
I just threw this in because this is by the way, this is a real patient. Luckily for her, she had an acromegaly that was the IGF-1 was elevated. And remember that prolactin is normal in pregnancy, 170. So do not
Most of
measure
things
prolactin
normal.
in pregnancy. That's another thing. Do
Yes.
not follow patients with prolactin in pregnancy. Prolactin can be elevated in pregnancy. This patient had acromegaly, and in one way, it was lucky because I was able to give her a high dose of cabergoline, suppress it till we could get her operated in the second trimester. Because it was early first trimester. She was in the first trimester, precious pregnancy. We couldn't get it out. Put her on a high dose of cabergoline, and then waited till 18 to 20 weeks, and then thank God everything else was good news. But this is an avoidable thing in our practice.
Dr. Krishna, what is
Okay.
the maximum dose of cabergoline you would give for these patients?
So I have patients who I follow with Cushing syndrome recurrence who I use up to 3 to 6 milligrams. The maximum dose I've used is 6 milligrams. The problem with cabergoline, but prolactinomas almost never require that much. Acromegaly requires it. Cushing's requires it. The most important thing is that cabergoline resistance is known. In some of those patients, going back to bromocriptine helps, right? And remember that if you're a very, very good surgeon, especially if it's a microadenoma, surgery works. And it's not like the olden days where we would say a surgery is not required. Not in macros, but a very good surgeon, a fantastic surgeon. When I mean fantastic surgeon with great hands, some microadenomas can undergo surgery, but please don't send everyone for it. The most important thing is that cabergoline very, very long term can cause heart valve effects. So you really want at higher doses. The dose is around 4 to 6 milligrams per week. If used for very, very long periods of time, can cause valvular effects. These are the doses that dopaminergic agonists have been used in Parkinson's and other conditions where they cause much higher problems. Well documented. But have I used cabergoline for years in patients in Cushing syndrome with recurrence? I've used cabergoline for many years and have been successful. Okay. Any other questions? then I think we can take a.
Yes, sir. Thank you, sir. Thank you so much, sir. That this was really a wonderful session, and we had a great panel discussion. Especially as fertility specialists, we were all very curious about the pharmacokinetics in obesity, and which was a long case discussion, which was very useful for us. And we had very clear take-home messages from the case discussions which we had today. Thank you so much, sir. Special thanks to panelists also,
Thank you.
Dr. Tara ma'am, Dr. Uma ma'am, Dr. Geeta Lakshmi, Dr. Bharat sir, and thank you all delegates for joining the session. Special thanks to our head of the department, Kundavin ma'am, for giving us an opportunity to collaborate with great speakers from other places as webinar, and we continue to do this session and hope to see you all soon in a session in 2026.
Thank you all. Thank you, sir. Thank you for the opportunity,
Thank you,
Dr.
sir.
Geeta
Yeah.
and Dr. Kundavi.
Thank you, ma'am. Thank you so much,
Thank
ma'am.
you.
Thank you, ma'am.
Thank you everyone for a
Thank you so much.
fantastic discussion. I really enjoyed it. Happy holidays to all of you.
Thank you, sir.
Thank you.
sir.
Thank you.
Thank you.
Thank you. Sahiti, a special thanks to you also. As usual, you helped us with the links today. Thank you.